My name is Irene Ahorlu. I'm a certified registered nurse anesthetist located in the United States, and I'm here with my colleague,
Dillis Poku Mensah.
Okay.
I am a family nurse practitioner and a psych nurse practitioner in the United States as well.
Excellent. Thank you, Dillis. We are representatives of the Professional Diasporan Nurses Foundation, Pdnf for short. And today we are with the Honorable Dr. Augustus K. Edwafo. And we would like to discuss some of the recent rise in kidney issues and diseases in Ghana. So we would like to educate our Ghanaian family about some of the issues with kidney disease, how to avoid it, and if you already have kidney disease, how to limit its impact in your life and complications. So please say hello to Dr. Edwafo. I will talk a little bit about him in 2 quick seconds. Dr. Edwafo, please say hello.
Hello. I'm pleased to be here with these great ladies.
Thank you. So Dr. Edwafo is currently an associate professor of medicine at Rice State University, Boone Shook School of Medicine in Dayton, Ohio. He is also a transplant nephrologist with Renal Physicians Inc. in Dayton. And believe it or not, he's also the medical director at DaVita Hemodialysis Unit, Trotwood, Ohio. And he was also a former medical director of Kidney Transplant Services, Miami Valley Hospital, Dayton. He's also a visiting professor of medicine at the University of Cape Coast Medical School. He's also an active member of the Ghana Physicians and Surgeons Foundations of USA, GPSF for short. We are very honored and thankful and grateful to Dr. Edwafo for gracing us with his presence today as we discuss some of the issues with kidney disease and hopefully educate our family about kidney issues.
Beautiful introduction.
You're welcome, doctor. So, Dr. Edwafo, since we know that a lot of our family members are big on herbal medicine, not all these medicines have clinical data to support therapeutic dosaging. Do these herbal medicines cause damage to our kidneys? And if they do, how do we limit the damages?
We know by way of the literature that certain herbs, especially certain Chinese herbs and certain herbs in the Balkan area like Romania and the rest, been noted and clearly shown to cause chronic kidney disease. Okay, the type of herbs that they use in Ghana is not akin to those used in China and the Balkans. However, since many herbs we know can cause a lot of acute kidney injury in terms of causing diarrhea and stuff like that, it is reasonable to assume that these may cause some type of kidney disease that we don't really know. This has to be an intense research in that field to determine. Our herbs are good. They do a lot of good stuff, good for us. And you rightly said the dosages are the one. There's one thing that gives us pause to think about. Maybe a calabash full of that herb may be too much to treat your asthma. So until and when the research is done and refined dosages, we will have to be careful what we put into our body. And many of these are incorporated into the various aphrodisiac in Ghana, like what we call that, the bitters. I don't want to mention one bitter's name to cause a lot of problems, but these bitters, last time I checked, there were about 45 to 50 different bitters. They have bitters that, a majority of them have been produced to help the men, sexual function. That's the key. 80% of the bitters are men action. Yeah. Yeah, there are so many of them. And if you go online and check it out, you will know that. But, who knows what these products, but these are not stuff that has been clearly defined in the scientific literature, especially in the Western. So it's hard to blame it on certain, but definitely there may be causative agent that will be a problem. But just whatever we take in, we have to be careful.
Okay, that's good. I
Thank
see.
you. So our next question is, how
Okay.
does the kidney function in our body?
Yeah. Thanks for asking the question. Kidney is a very important organ in the body, and everybody talks about the heart and the brain. That's correct. But the kidney also plays a very vital role in the way the body is shaped up. Our kidneys are the sizes of our fist. Okay, everybody's kidney is the size of your fist. And they are located and usually below the ribs, in the lower abdomen, and they're connected to a series of pipes and filters, which is made up of blood vessels. Okay, so the major function of the kidney are about 5 or 6-fold. First, it actually is the only organ that removes excess toxins from the body. What I mean by toxins, when you eat, the good food the good stuff in the food is used to provide energy. The residue end product are broken down by the liver, and the kidney gets rid of it. Okay, so if the kidney doesn't work, that means this poison will build up in the body, and it gives you a symptoms that we call uremia, kidney failure. So that's one. It removes the poisons. And also when you take any medication, the medication does the job. It has to be broken down and then eliminated through the body. And the kidney is the one that removes the excess breakdown products of medications. Okay, so that's one. It's also the organ that maintains fluid status. That's why we pee, you urinate, because you drink and you pee it out. If your kidney doesn't work, then it means that all the fluid that you drink in the body will be retained and gets you to swell. There are 3 sources of water in the body. What you put in your mouth, drink. Number 2, every food that you eat, however dry the food is, has some water in it. And 3, the metabolic process in the body also generates water. So you can't control that. You can't control the food, the water in the food that you eat, but you can control what you drink. So the kidney is the one designed to eliminate excess water to maintain the balance. The third thing it does is that it maintains what we call electrolytes. There are certain electrolytes in the body called sodium, potassium, calcium. They are very important for cell function and from substances in the kidney, in the body called enzymes and hormones. They require these electrolytes in the right amount. And kidney is the one that maintains the balance. Whether you have to get excess, get rid of them, and keep them, that kind of thing. It's very important. So, for example, potassium. If the kidney doesn't get rid of the potassium and the potassium builds up, it's going to cause irregular heart rhythm and you can die from heart failure or heart attack. Okay. It also maintains your calcium. Calcium is important for muscle action. Get out of your muscle, you lift weight, it's all due to calcium action. And calcium is actually the level is improved in the blood, maintained by what we call vitamin D, which is produced by the kidney. Yeah. So apart from the electrolytes, kidney also makes what we call hormones. Most people don't know that, but there are 3 basic hormones that the kidney makes. It makes a hormone we call vitamin D. The vitamin D that everybody talks about is completed in the kidney. So it starts from the skin, goes to the liver, and completes the kidney. Once the vitamin D is made in the kidney, it goes into the intestine and makes you absorb the calcium from the food. The calcium then has muscle contraction. So when you have kidney failure and you don't have vitamin D production, then you don't absorb calcium from the food. The calcium level goes down, you become weak, and yada, 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 certain things happen. Okay. In addition to that, the vitamin D hormone, there's another hormone called erythropoietin. This is the hormone which tells the body to make blood. Blood is made in our long bones of the hands and the legs. And the hormone that tells the body make the blood is called erythropoietin. Everybody's blood in the body is broken down every 120 days. So the blood in your body 6 months ago is not the same blood that you have now. Every 120 days, the blood is broken down. New ones need to be formed. And so the breakdown continues, but the impetus to form a new ones is based on the erythropoietin that tells the body. With the kidney function less than 30%, you cannot have erythropoietin production. And therefore the blood breaks down, but new ones are not formed. So progressively become anemic. So every kidney failure patient becomes then develop anemia, which eventually we're going to talk about some of the complications that leads to death. Okay. And finally, the kidney maintains what we call acid base, because the body has to be neutral for the hormones to work. So if the acid build up too much, the enzymes and the hormones will not work. So the kidney is charged with the responsibility of getting rid of the acid and maintaining homeostasis, acid balance. So when the kidney fails, acid builds up, you are in trouble. So those basically are the functions of the kidney. So everything that happens to the human body is based on these functions. But the kidney is not there, and that happens. And just on the same subject, when you have a kidney disease, it is absolutely important to distinguish between acute kidney injury and chronic kidney disease. Acute kidney injury almost invariably resolves and gets better, and you can come back to the baseline. And usually, commonly, it's due to dehydration in terms of when people have diarrhea, vomiting for a short period of time. Because when you become dehydrated from diarrhea or vomiting, or you couldn't drink enough fluid, your blood volume goes down. So when the blood volume goes down, the body is told, listen, your blood volume is down. What can you do? The body will say, let me send all the blood to the brain and the heart to work, leave the kidney and other organs without any blood. And therefore, the kidney get mad and the poison build up. Okay, so that's acute kidney injury. It can happen when men have big prostate causing obstruction. And when you identify and remove it, you can fix that. You can also develop acute kidney injury when you take certain antibiotics in large amounts or certain medication like ibuprofen or Aleve, what we call NSAIDs. All those, or if anybody has a chest pain, they give you a CAT scan with IV dye. It can cause you to have acute kidney injury. Those in instances are due to the kidney failure within less than 2 months, 3 months. Those 95% of them will recover. That will not lead to end-stage kidney failure. When we talk about chronic kidney disease, it's a problem. That means the filters are damaged and the condition is going to progressively get worse. And that's where the problem is.
Okay, Dr. Duafo, I just want to ask to clarify this. I'm so happy hearing all these things. But knowing myself, even me, and knowing my population, somebody will be like, oh no, I'm not going to do any CAT scan because if you give me a dye, I'm going to get end-stage renal failure. That is a short period, which is acute. And eventually, you said it's going to correct. Is it?
Yeah, it's going to correct. I mean, it's not everybody who gets a CAT scan or IV contrast and gets kidney failure. There are certain risk factors. Okay, the single most important risk factor is underlying chronic kidney disease. Okay. Say when your kidney function is say like 30%, 35%, of course, that means the nephrons with the filters are few in numbers. So it doesn't take much to knock 1 or 2 out, and then the kidney creatinine is going to go up, and that will recover. And underlying chronic kidney disease, or when you are dehydrated, it is really not the dye that causes the problem. It is the contact time between the dye and the renal tubules. So when the dye is filtered and in the tubules and it stays there for a long time, it can cause a damage. Why am I saying that? So when you are dehydrated and somebody gives you a dye, that's where the problem is. Dehydrated kidney doesn't send urine throughout. Everything is stagnant. So when you give a dye in that period, stays in the kidney for a longer time, the longer it stays, the more it damages. So what we do is that in this situation, we give you IV hydration before and after the dye test to establish a rapid transit of the kidney. So when in the urine, so when the dye gets into the kidney, it is flies up very quickly. The other thing that also leads to contrast is when you have repeated contrast at short interval. You have CAT scan of the chest today, then tomorrow you do a CAT scan of the brain, 3 days later you do a CAT scan to look at bleeding in the abdomen. You are going to be in trouble. Repeated exposures. So as physicians, we put all of them together and decide when to do it and what not. But currently, it looks like it is oversold. I mean, the dye is dye. You have to do it. And almost everybody recovers. Even if you require dialysis, it's a very short period of time, you'll be fine. I don't stop anybody from having undergoing CAT scan, knowing very well that it will give you a diagnostic result, and also it will fix the problems. Yeah. So that you identify and fix the problem. All right.
Thank you for saying that. Thank you for saying that.
Yes, thank you. That's a lot of really great information, Doctor. We thank you. The next question that we'd like to know about is, what are the most common kidney diseases or conditions that you encounter in your practice?
We're talking about chronic kidney disease to benefit Ghanaians. The practice is skewed. A lot of where we live in the Midwest, a lot of white folks. So it makes it a little bit different. But in terms of my own personal practice, I'm a transplant nephrologist. So if anybody who gets a kidney transplant and lives in Dayton, whether the transplant was done here in Dayton or Ohio State University or University of Cincinnati or Michigan come to see the African dictator, and that's me. Because kidney transplant is a very essential commodity. You can't get it and screw up. I will take you to the cleaners. They all know me. They call me the African dictator. Okay, so 80% of the people I see are the transplant. But meanwhile, in terms of my general nephrotic practice, the basic thing is that chronic kidney disease from diabetes and hypertension, uncontrolled hypertension, and glomerular inflammation. Those are the ones I see. And occasionally, pregnant women have a lot of few kidney issues that are specific for pregnancy that they call me and my colleague that we go fix them. And those are the things. But kidney disease, the chronic kidney disease is actually diabetes and hypertension. This is the 80% of the time.
Okay.
Yeah, it may be different. In Ghana, I can tell you, all my colleagues in Ghana are experiencing. It's also chronic kidney disease in more Ghanaians, part of sub-Saharan Africa, hypertension. We will talk about the risk factors.
Okay.
Yes, thank you. My next question is, what are some of the symptoms and warning signs that we should look for, especially in Ghana and the sub-Saharan African areas, so that we can prevent getting these diagnoses?
Unfortunately, 85% of people with chronic kidney disease don't have any symptoms. Unfortunately, kidney is a very silent destroyer. It's a silent disease. It doesn't cause symptoms. So based on that, let me explain some few things. And by the way, when you have a kidney dysfunction for more than 3 months, that's what we label you chronic kidney disease. Anything more than 3 months is with a kidney disease called chronic kidney disease. Okay, and based on that, there are 5 stages of chronic kidney disease based on the percentage function of the kidney. The kidney is a very vascular organ and usually works around 120%. When the kidney drops from 120% all the way to 90%, we call that stage 1. Okay, usually everything is fine. You don't have any symptoms, nothing. So when the kidney function drops down under 90, all the way to 60%, we call that stage 2. Again, also has no symptoms, nothing. Then when it drops on the 60% all the way down to 30%, we call that stage 3. That's when they begin to see kidney specialists. Stage 3 also doesn't have any symptoms, but you can pick it up with blood tests, a urine test. So then when you go to stage 4, kidney under 30% all the way to 15%, that's when you begin to have symptoms which is associated with the retention of the poisons. Okay, the first thing that happens is nausea. Like in a woman, it's the same as when you were pregnant, morning sickness. You are nauseated all the time. And then appetite is very poor. Those are the things that go to late stage 3 and early stage 4. That means you are getting ready to do dialysis in stage 5. So stage 5 is when the kidney function is under 15. So 15 to 29 is stage 4. And under 15 is stage 5. Stage 4 is when we prepare you for dialysis. In stage 5, when we give you dialysis. Okay. So in stage 4 and stage 5 is where we have the symptoms. So usually GI symptoms, nausea, and loss of appetite. And then you begin to swell. I told you that the kidney gets rid of excess water. So when the kidney doesn't get rid of it, the water remains in your body and you're going to swell. So legs get swollen at the first common area that is swelled. And then if nothing is done, then when you lie flat in bed, it goes into your lung, you have difficulty in breathing. Okay? So that, and then the poison seep into your skin. You itch like crazy. They call that general pruritus. When you get to that point, you'll be scratching. In my hometown, they'll probably label it, blame it on me. Okay?
As usual.
Okay. And then if nothing is done, then you begin to have muscle weakness and muscle twitching. The twitching and the weakness is due to the potassium and the calcium level being low and high. And then finally, it gets into your brain, you can't think right. So you get confused. You can't even remember the name of your wife. And then if nothing is done, you sleep 22 out of 24 hours a day, and then you become, you have a seizure, and then you die. Okay, we don't like to read that. So those are the late symptoms. But the early part, and the reason why I'm bringing it up is that the only way to pick up early kidney disease is simple urine and blood tests. How do we get Ghanaians to do simple urine and blood tests? knowing very well that 70% of Ghanaians live in the rural areas where they don't have access to healthcare. That's a problem. When I gave a lecture in Ghana a lot of time, that's what, how are we going to get to these people? Okay, so the single most common test, simple, cheap test to pick up kidney disease is urine test called urinalysis, which costs less than $2. And what you look for is proteins in blood. Once you have a small amount of protein in the urine, it tells you this patient has chronic kidney disease, is going to progressively get worse. That's what you can pick up. Okay, and that's the thing. But even before that, you have to have somebody who has a risk factor to be able to come to you for you to do those things. So when we discuss the risk factors, we will talk about because you know there are so many nurses in Ghana who have graduated. They have not even placed them. My auntie's daughter is a nurse. Yeah, finished nursing school. They have not even placed her for the last couple of years. Why can't we get these nurses to man health posts in the villages? Right, so that people will come in and we do simple urine and blood tests. And when we see a problem, we refer to the district hospital. Because that's how Ghana healthcare system is about. It's a health post, district hospital, regional hospital, and then university hospital. That's how. All right. So I remember when I was in the Kwanta, you know, people don't, if you come in and say, I want to do physical, you kick away. So we are busy. We don't do those. But, oh, yeah. It's true.
And that is the only way we are going to catch these things in the early stage.
And it still happens in Ghana. Nobody does the internet. So we have to change the mindset. Go for the patient and healthcare providers so that we can be doing
preventative.
I have few suggestions that we can discuss so that I can.
That's great.
Yeah,
so, that's great.
So that's the bottom line. So that in terms of symptoms, it's late, and we want to catch it long before, because if you catch it early, you can make a difference. Okay, catch it early, you can make a difference. I've had people with a stage 3 chronic kidney disease that I pick up, and it's been 20 years. It never progressed to stage 4.
Wow.
Can I divert a little bit before we go to the next question? Can we use diuretics to help with this when somebody's in stage 3 and the person's feet is swollen, sometimes can't breathe and all? Can we use diuretics to help?
Absolutely, no? Because if the kidney is not doing the job and getting rid of the water, what do? You have to scoop the water out. The only way you get the water, and that is the chronic kidney disease, and a patient comes in with shortness of breath. When the patient comes in with shortness of breath and a chronic kidney disease, I'm afraid to give large amount of diuretics because it may worsen the kidney. Hello, what are you doing? There's no magic, okay? And the amount of diuretics you give, the dose is related to the proportion to the kidney function. I see people with a stage 4 chronic kidney, they come to the hospital because doctors are afraid, they give them 20 milligrams of laxatives. Are you kidding me? The dose of the diuretics are not enough. You have to give adequate for you to. So when somebody is swollen with a chronic kidney disease, you cut down the amount of water they are drinking because you are dumping too much water in your body. And therefore you have to cut it down. You cut down the amount of salt you are eating because salt retention goes along with water. And finally you give diuretics. So it is not only the medication that works, it's the lifestyle that should work with you. The salt, down the water, and take your diuretics, you'll be fine. Now, that doesn't fix the kidney problem. It just alleviates the swelling. Okay? And therefore, you're going to have to do other things to stabilize the kidney. So there are certain risk factors which are clearly being shown in the research. In the whole world, there are about 350 million people in the world with the chronic kidney disease. Only 2 million are on dialysis, but there are 350 million people in various stages of chronic kidney disease. Okay? Wow. The most common risk factor is diabetes. Okay, diabetes causes about 40% of all chronic kidney disease, whether blacks or whites or Hispanics. Okay, but in black people, uniquely, the most common cause is hypertension. Okay, so hypertension is about 40% in blacks and 35% diabetes in blacks, but it flips when it's a Caucasian. Diabetes becomes more common, hypertension becomes. So between hypertension and diabetes, these two diseases constitute 75% of all causes of chronic kidney disease. So if you fix your blood pressure and diabetes, you are clearly avoiding chronic kidney disease. So those who have hypertension for a long time and diabetes, and then individuals who have a strong family history of kidney disease, your mom, dad, aunt, or something was on dialysis or kidney disease, you have a higher risk of developing that. So those are the risks. And finally, individuals who are smokers. You smoke, you increase your risk. of kidney disease. Some individual who drink too much alcohol increase the risk of kidney disease. And then in individuals in Ghana who think when you become big, it's a sign of affluence. Obesity is a risk factor for chronic kidney disease. Apart from the chronic kidney disease, obesity will make you develop stroke and heart attack and die. Okay, so being big alone is not enough. So obesity, and then of course, studies have shown these days that vitamin D deficiency has been shown to be a risk factor for chronic kidney disease. And you know, blacks, 85 to 90% of black people, and I'm going to challenge you in your practice, please do vitamin D level of all your African American patients. Yes. I'll tell you, I did mine and mine was in the toilet. I was shocked. Yes. Vitamin D starts from the skin, go to liver and complete in the kidney. It turns out that the melanin in our skin blocks the ultraviolet rays that manufacture the start that in our skin, and therefore most black people have vitamin D deficiency. And it turns out that vitamin D, when in inadequate amount, prevent the damages in the kidney. On top of that, when you have another lifestyle change, that excessive salt intake will put you at risk. But the two biggest risks are hypertension and diabetes. But for sub-Saharan Africa, there's a new entity. We just found that there's a genetic predisposition to kidney disease in black people. Genetics. Oh. Yeah, genetics. And that is called APOL1, APOL1. Apolipoprotein 1 gene mutation. Okay. Yeah. Apolipoprotein 1 was recently found to be dominant in blacks in sub-Saharan Africa. And apparently God put it there to prevent trypanosomiasis. Oh. So when you have that, you don't have a sleeping sickness. It turns out that if there's no sleeping sickness anywhere, then some genetic the mutation of these genes can lead to kidney disease. Clearly, it's a one come from the mother, one come from the father, and there are three types: GO, G1, and G2. If the GO doesn't have any risk for kidney disease, when a G1 from the father marries the G1 from the wife, then the child becomes a patient with risk of developing kidney disease. It doesn't mean that when you have these abnormal genes, you are definitely going to get a kidney disease, because only 1/3 of patients with that abnormal gene will have kidney disease. It appears some other environmental factors have to set in to combine with the genetic predisposition to get a kidney disease. So black people have the genetic disposition. All over the world, whether you are in sub-Saharan Africa or in the Caribbean or United States, African American, blacks are black. You all have the same risk factors. High blood pressure, then gain, yada, everything.
Oh, we have everything.
We have everything, but we are good too. We look handsome and beautiful.
Yes, yes.
So, with all that I've heard, that is really scary. I'm sure whoever sees this education session will be like, wow, I know we are here, but our population in Ghana, our families in Africa, what steps can we take to prevent these unhealthy kidneys from developing?
Okay, just remember that kidney failure, when it leads to end stage on dialysis, is a very expensive proposition. Very expensive. All right, and that's why there are 2 million people in the world with dialysis. 80% are only in 15 countries. Yeah.
Oh wow.
Yeah. Why? Because it's very expensive. You know, we don't even have money to pay workers or do other things. How can we pay for dialysis? That's the problem. You know, it's a wrong priority. Yeah, you know. So the idea is we don't want it to get to the point where they reach end stage. Apart from the cost, you're also going to die. Okay, you go on dialysis. I'm not missing words. Anybody on dialysis, you forgive me, but it's the truth. You have 4 or 5 times the risk of dying from heart attack or stroke when you're on dialysis. Okay, so it is not cool to progress to dialysis. That's why we try to. In most people in Ghana, they don't even do dialysis long enough for them to get this complicated. But they die because they don't have enough money to do regular dialysis 3 times a week. Most people do 1 or twice a week. So in Ghana, so you know, this is not unique to Ghana, because in the United States, the dialysis is paid for by the Medicare. That's why they are lucky. If it was paid by individual, people won't be able to do it. That's right. You go to India, there's no payment. The government doesn't pay for dialysis in India. It's individual. China, Russia, nobody does that. It's only United States, Canada, France, Italy, the so-called developed. And in Africa, probably South Africa, no country in Africa pays for dialysis for its citizens. But you can do some subsidy. In In even South Sudan, they pay 15 to 20% for each patient, and then the family do the rest. So the idea is to prevent this from happening. So which means we have to identify those at risk and mediate. Okay, those at risk are individuals with high blood pressure, individuals with diabetes, individuals who have family history of that. I mean, most people, even when we are growing up, your parents have disease, they don't even tell you what they are. You don't have no idea.
Yeah,
Family history, nobody
that's
tells
the
you.
bad thing about Africa.
Yeah, even when your mom is pregnant, they don't tell you. You go to hospital, you come back with a baby. Say, this is your new because kids are considered not very relevant in Africa.
Yeah.
So that is to identify the risk factors. So the first thing is to go into the hinterland, get to everybody who has the risk. So it means that's why I said everybody in Ghana is a Christian, about 80%, and about 20% go to Muslim. Okay? There's no way you can manage healthcare and evaluate in terms of kidney disease without involving the pastors.
Yes.
There's no way.
Yes.
Everybody, you go to villages, they go to church in their classrooms. So and other health should meet with all the pastors to incorporate this in their sermon. Every week when they talk in the Sunday, they should spend 5 minutes talking about, hey, kidney disease is common with us. Let's do a test. Please go to the hospital and get it done. I'm telling you, once they hear from the pastor, they'll go and do it. So that's the one thing. And I keep on, I'm going to send a message to my friend who is a big pastor in Ghana with a big church. I'll mention his name. When he hears, he's not going to get mad. Pastor Mesota is my mate from 1 to 5.
Excellent.
Yeah.
Excellent.
So in churches like that, it's very big, and then they can have like twice a year health fair, where nurses and healthcare workers can come in and check, or doctors can be invited, check people's blood pressure, check some peripheral blood for lipids and stuff, check urine test. So those who we pick can be sent to the hospital polyclinic for evaluation. So if we do this in every region, in every district, in every small town, it can help us. And then we also have to involve our chiefs in the various villages. That we have to let the chief know that for the survival of your constituency depend upon the healthy life of the citizens. So let's have them every once a year. Let's do all this. They do harvest and all the stuff to raise money to improve the town. Why can't we do health fair in the various towns?
That's right.
Okay. So once we do and UA doesn't cost much, and blood doesn't cost much. And if the money is not there, we can solicit the help of the rich people in the town or the NGOs to help and pay these little things so that you can pick up. And then there's this guy who has converted his van into a mobile clinic. He was given an award by CNN.
Yeah, on CNN, yes.
Yeah. So I mean, something like that. Why can't we emulate it and do more? Go to the rural areas and try and do this to try and pick up. Once those are picked, then we're going to be very aggressive in managing the blood pressure and the diabetes. And that brings me to blood pressure medications, where a lot of medicines in Ghana are fake and they don't work. Okay, I know. So whoever is in charge of allowing these fake medicines to be shipped to Ghana should be ashamed of him or herself, knowing very well that these medicines don't work. Because there are certain pharmacy shops, when you go, they'll tell you, hey, this medicine, amlodipine. I went to Ghana, I take amlodipine. I went to this pharmacy shop, and the guy told me, hey, this is from abroad, England, it's good. This one is from Nigeria, it doesn't work. But if you know it doesn't work, why are you selling it? I'm not kidding. Nobody told me.
What?
I said, why are you selling it? Yes. And nobody goes around and takes care of this. And so our, policymakers should be making a point that they have a proper medicine at a reduced cost so that people can take it.
Do we have anything like the FDA or DEA in Ghana? Do we have anything like that?
Yeah. Food and Drug Administration, they are very good. They go around and but see, it's very difficult to, it's still there, but people do all this aphrodisiac without they don't even have any tests, and then they keep on selling them. And it's difficult. I think they are doing the best they can, but it's our people need to be educated more so that they don't subject themselves to all these little things. That the better if even if the drug is good and it's expensive, how good it is. You know, I mean, people go in and they buy, my doctor, me talk a property, do me need get for 1 week supply. So you get it for 1 week and he goes, and when the headache goes down because the pressure is better, he forget about it. And then one man doesn't take anything. The next moment he had a stroke, and then they'll blame it on the lady in the village who didn't have children. On the way. So it's about bringing the right medicine, subsidizing, and making sure that people can afford it.
Yes.
And that's and then on top of the medication, we do our lifestyle. No medicine will work without lifestyle modification. Okay, you can take all the medicine in the world. If you're obese, smoking, eating like crazy, not sleeping, you are not going to make any headway. Yeah. Our women, I'm sorry to say, they don't like to wear dress because they are big. Because when they have children, they don't exercise, they don't do anything, and it's not their fault. Because what they do is so demanding in our women. But we leave everything for the woman to do. They're so demanding, they are so stressed. They can't even take care of themselves. And then they increase in weight. And when that happens, you know what happens? And the man has to marry a second or third wife.
No comment. No comment.
I think it looks like he has screening and diagnosis as Ms. Irene.
Yeah, he talked about the urine test and the blood work.
Yeah.
So any more screening tests left?
Yeah. So the urine test is the single, very basic, very simple. And then you do the blood test. The blood test will categorize you whether you have a normal kidney function based on a simple blood test or what stage of kidney disease you have. And when you are stage 3, which the blood test will tell you, then you have to spring into action. So 3 stage 4 action, and then that's why you are aggressive. And then based on these 2 blood and urine tests, then if there's money available, you get an ultrasound of the kidney. Make sure to do it, because if you send somebody to ultrasound, if you haven't done urine test, in my opinion, it's useless. Do that, because one of the small, even though it's a small cause of chronic kidney disease, there's something called polycystic kidneys. Okay, it is not more in sub-Saharan Africa, but listen. And everybody with a new kidney failure should have an HIV test. That now the HIV is the most common infection causing chronic kidney disease on the island.
Wow.
Yeah, in sub-Saharan Africa. Nobody dies from HIV anymore, but they are having a lot of kidney disease. People are not aware of that. Apart from diabetes and hypertension, HIV is very important. And these days, people with severe COVID, when they recover, may have a kidney damage.
Yes.
Okay. And one of the things that I didn't touch on, which is very important, is low birth weight children. Okay, prematurity. Low birth weight children is very common in the poor communities in sub-Saharan Africa. Low birth weight is you are very small, and one of the things that happens has been shown is that the kidneys are small. Okay, the nephrons don't mature, so you have a low nephron numbers. So by the time you get older, you have a disadvantage of having low flow test, and that 50% of these individuals will then lead to kidney failure. That's one of the reasons why kidney failure is very common in early age in Ghana. Okay, the hypertension in Ghana, or let me say hypertension in sub-Saharan Africa, have 4 characteristics. A, it starts early in mid-20s. B, it's difficult to control. It's a stage 2 hypertension, so it requires 2 or 3 medicines to treat. Number 3, it has so many end organ damage at the time you see the patient, left ventricular hypertrophy, kidney failure, and stuff. And finally, it leads to end-stage kidney failure very quickly. So that's why most people by 35 years old, they're already ready to go on dialysis. It started 18, 19, or 21 years.
Wow.
Okay, that's why I'm saying that individual with a risk factor, like the mom was on dialysis, father on dialysis, type 1 diabetes, hypertension, you need to get to these people. And especially in the high schools, those with a family history of diabetes, hypertension need to be screened in the high school. You know, you come for the school feeding program, you come in and we do a urine. Make sure that your urine is fine. We are not doing the urine to look for drug use. I mean, how many of these kids use drugs? But listen, and everybody talks about NSAIDs causing a lot of kidney disease. Yes, you have to take the NSAID for over 5 years for you to have a stable kidney disease. Taking 1 or 2 tablets of ibuprofen will not cause any problem. I think it's oversold. Doctors, listen. Of course, when you are dehydrated and you take ibuprofen, you're going to have acute kidney injury, but that will recover. But for you to eat NSAIDs every single day for 3, 4, 5 years, you're going to develop what is called anergistic nephropathy. Your kidneys are going to be small and going to be on dialysis. And an individual with lupus also can have end-stage kidney failure. Fortunately, less than 2% of them will lead to kidney failure. It's not very common. But if you knock off hypertension and diabetes, we're in good shape. So I mean, my only concern is how to get rid of even those in Accra. You know, you live in Choco, your condition is the same as you live in Mangasim. I mean, this is a terrible. They don't go anywhere, and they go to the hospital when they are sick. That's not enough. We need we need evaluation at least once a year. Everybody above the age of 35 should have to have physical once a year. And if they don't have money, somebody should pay for it.
Yeah.
There are so many rich people in Ghana that they don't know it, but if you let them know, they can help.
Yes.
They're not supposed to be using the money on you, but some of them are very good. And if you tell them, I know good people, they will help.
Yes.
You know, so we need to have national dialogue to try and help out. Because when you reach end stage, you are in trouble. When you go to dialysis, you're in trouble. I mean, last time I reviewed and presented the plight of dialysis, I think this January in Ghana. You know, Bono region, Upper West, Upper East, there's no dialysis there.
Yes. Wow.
If you live there, in the whole Western region, there were 2 machines. So you live in Elugu, you have to drive all the way to Sekani, Eshekwanta to come dialyze. Why? Cape Coast is good. They have about 10 machines, 8 to 10 machines. So if you live in Sierra Leone and Gizmo Winneba, you have to go all the way. It's not. I think we should be able to do better. So we don't want to get there. We want to prevent this from happening. And by the way, that prevention that you said, once you put the risk factors, then you control diabetes and hypertension. Then there are certain medicines you give to that person that will preserve the kidney function from going down. We call them the ACE inhibitors and angiotensin receptor blockers. Everybody in Ghana, in the South Africa, should need to be on either lisinopril or any of its cousins, or losartan or any of it, because unless they have allergic reaction that you can't give. Of course, some individuals with ACE inhibitors can have angioedema. You can't give them those things. But if you want to give a good blood pressure medicine to anybody with a chronic kidney disease, you have to be ACE inhibitor or ARD. You don't give this. And then appropriate diuretics, that kind of thing. And once that is done, because you look at the medication they give for people with a chronic kidney disease, amlodipine and all that stuff, they don't affect the kidney. They don't make the kidney better. So you want something that will work inside the kidney, make it better, and also keep your blood pressure under control. That's the ACE inhibitors. And I was very pleased that so many of my cousins, my aunties went to the hospital. They were giving the ACE inhibitors in Ghana. I was I said, wow, this is Sopon Hospital. This is not Kolebu, Sopon Hospital. The guy there was very good. He's reading the literature. He's doing the right thing.
That's awesome. That's great.
But even when they give you the prescription and you buy it from the local pharmacy, the question is it, in those areas, they remove the literature insert from the drug, so you don't know whether it's expired or not.
Oh my God.
Oh yeah, you don't know. So they sell it to
you.
You're funny. No, that's they take it away.
He knows all the tricks. He knows all the tricks.
And you are happy. You are happy that you get the medicine, but medicine have been you have maybe expired over 2 years ago.
Oh my God.
Yeah, I know. So we have to do better, but at least we can save some life. We can't do everybody. We can't save everybody. But I'm very positive, strong, engaging our pastors and our chiefs in the traditional area.
And the imams.
Do you agree to the fact that we should start educating our people at home for preventative medicine, as in going for yearly physical? I mean, everybody's concerned about the money that the doctor will take from them, but I believe if they can do yearly.
I agree. It's absolutely important. So this is where, you can use the pulpit to try and educate the people. And then on top of that, on radio, because there's so many these herbal. One herbal stuff can do so many things. And you see you hear about them in the FM station. When I talk to them, they say, hey, the advertisement brings us money. I'm not going to stop. And then if you look at our TV, everything is dancing competition in the TV. They don't talk enough about health. That's what I'm talking about. I think we should invest a little bit more in but Of course, if you go to rural areas, not everybody has TV that we watches, but everybody go to church. That's why I'm very positive that the pastors can do better by incorporating the health education. Even what my mom used to tell me, whatever he hears from the Roman father, it gets into the brain better than anybody tell anything. So I'm very definitely that the pastors can do a great job of. So you have to appeal to them. But you know, most people when they have headaches, the first person they call is their pastor.
Yeah.
It's a pastor pray for me. The pastor will pray. So good pastor will say, "I'm going to pray," and then you go to the hospital. Okay?
Correct.
Yeah, I'm a Christian, but I think God also has given us enough common sense to know that this is what you have to do. You take the medicine and you pray about it, and then the disease is better. You don't pray alone will not fix you. You know, I mean, if you don't do that and you develop a stroke and you die, God is going to ask you, "Are you stupid? I didn't create this medicine for nothing." You take it, and then you pray, and then I will help you to make it well. You don't just pray and then not taking the medicine. You are and for that reason, I'm putting you in hell. That's what God will tell you.
It's very good. Good information.